Hello, good afternoon, everyone. Wow, it is such a great joy to have you all here with us today. And honestly, I couldn't be happier to open this very special event hosted by IC&C. Today, we have a guest who hardly needs an introduction, but I really want to say how much of an honor it is to welcome Dr. Judith Beck here with us. Thank you so much, Dr. Beck, for accepting our invitation and for sharing your valuable knowledge with all of us. Your presence here is a truly gift. And if I may share something personal for me, this moment is very, very special. Not only as a psychologist, but also as an autistic person. I face many, many challenges every single day. And CBT has been a real source of transformation and hope along my journey. So being here today is a privilege that will always remain in my life and, of course, in the history of our institute. I'm a bit nervous. And I just realized now that I got so emotional that I didn't even introduce myself yet. Sorry about that. Uh, my name is Vivian Bueno. I'm a clinical psychologist and I work with CBT. I also provide neuropsychological assessments, and right now I'm finishing a postgraduate program in neuroscience, behavior, and psychopathology. I'm the co-founder of IC&C, the Institute of Cognitive and Behavioral Interventions, and also of Skutaki, an online psychotherapy platform. Skutaki was born during the COVID-19 pandemic. At the time, uh, online therapy sessions were still uncommon in Brazil, but with a sharp increase in cases of anxiety and depression, we saw the need to create something that could provide access to mental health support, which, as you know, is still very hard to reach for so many people. We're still a small company, but with the support of our partners, psychologists, we have already donated more than 100,000 psychotherapy sessions to people in vulnerable situations. And just to give you all an idea of what it means, I once worked with a patient who attended therapy before taking her first hot shower in her life. She came to the session saying uh, she felt strange sensation. Sorry, she felt a strange sensation on her head. And later, we realized it was simply because she had washed her hair in hot water for the first time while staying at a friend's house. Um, in 2024, ICC was created with the same mission of generating access, but this time access to knowledge. Our goal is to provide free evidence-based content so that mental health professionals can keep learning and updating their practice. And now, before I give the floor to Dr. Beck, I'd like to share a few thoughts with you. All of us, as therapists in CBT, began our journey with a clear and powerful map. Of course, the cognitive model. We learn to identify automatic thoughts, to challenge them with evidence, and to use behavioral strategies. And this map has guided us through many challenges. But sometimes the territory of human suffering turns out to be more complex and more intricate, and even darker than what our first map could ever predict. CBT has grown a lot over the past decade, with so much new research and the expansion of its practice. The way we the way we conceptualize and treat cases has also evolved. Of course, the negative aspects of people's experiences, their problems and symptoms remain central, but today we also know how important it is to look at aspirations, strengths, and personal resources. That means motivating our clients with what is most valuable in them, their passions and qualities, talents, their values, and the sense of purpose. It means helping them draw um, positive conclusions about themselves and their own experiences. When we explore a recent experience that brought the patient a sense of well being, uh, we create space for them to reconnect with positive emotions, both within and beyond the sessions. You know, and this, of course, does not replace the work we do with symptoms or obstacles, such as practical problems and automatic thoughts, but it expands the conceptualization to include strengths, achievements, values, and talents. In doing so, we don't just reduce suffering, we also foster motivation and resilience and a sense of purpose. And nowadays, within CBT, we also find techniques we have been adopted into the cognitive model from other psychotherapies, such as DBT and ACT and mindfulness. These adaptations expand our clinical toolbox and help us to find solutions even in challenging cases. And this is why keeping ourselves updated is so important, because sometimes the basics don't work and the patient doesn't improve as expected. And in those moments, we need resources to think differently and truly move forward together with our clients. Our clients, sorry. And now, with great pleasure and deep admiration, it is my honor to give the floor to our special guest, Dr. Beck, who will guide us through this important reflection on going beyond the basics in CBT. Thank you very much, all of you.
So today we're going to talk about CBT beyond the basics. And at the end of my talk, I'll talk a little bit about the work that my father did at the very end of his life. For about the last 15 years of his life, he and one of our team at the Beck Institute, Paul Grant, and colleagues developed recovery-oriented cognitive therapy, which is certainly beyond the basics. So we'll talk a little bit about that then. My father was so passionate about his work. We think that that's why he was able to live to the age of 100, because he worked until 2 days before he died. I'm hoping that I will inspire you during this talk, and you'll want to find out more about the free resources that we have at the Beck Institute. I hope you can see on the screen that you could email us at help@beckinstitute.org. And then in the subject line, put IC&C 2025, and we will send you a list of all of those free resources. We have a small clinic at the Beck Institute, but mostly we do national and international training in CBT to mental health professionals from around the world. Being a good CBT therapist, I need to set an agenda and tell you what my goals are. I always have the same two goals when I give a presentation. So if you've heard me before, you've also heard these goals. One is to teach you some things that you might be able to use tomorrow, ways of conceptualizing your clients, and also ways of translating that conceptualization into a treatment plan. So we'll be talking some about CBT interventions. But my larger goal is really to motivate you to go well beyond this talk to learn more and more and more about CBT. Here's our agenda. First, we'll talk about what is CBT like in 2025. It's very different from how it was when my father first developed it in the 1960s and 1970s. But we will talk a little bit about how he developed CBT. Then we'll spend some time talking about cognitive conceptualization and the essentials of treatment. And finally, we'll talk about recovery-oriented principles. So I hope that that agenda sounds okay to you. Some people think that cognitive therapy or cognitive behavior therapy is defined by its use of cognitive and behavioral techniques, but that's not how we define it at all. We define it as a psychotherapy that's based on the cognitive model, that what all psychological disorders have in common is at least some degree of dysfunctional thinking, and that the way that a person feels and behaves is very much influenced by the way he interprets his experiences. Now, I know most of you probably are very familiar with modifying patients' negative cognitions that have led to their negative moods. But in CBT in 2025, we also pay a great deal of attention to patients' positive experiences, the ones that lead to a positive mood. But it's not enough just to have positive experiences. We need to help clients draw conclusions, positive conclusions about these experiences. Now, CBT, as I said, is not defined by its use of techniques because actually we integrate techniques from any evidence-based treatment. And here are just a few of them. We integrate techniques from DBT and acceptance and commitment therapy, from motivational interviewing, from positive psychology, from interpersonal psychotherapy, compassion-based therapy, mindfulness-based cognitive therapy, from the experiential therapies, supportive psychotherapy, and even psychodynamic psychotherapy. As long as we are conceptualizing the client in terms of the cognitive model, then we can use techniques from any of these evidence-based treatments integrated into our treatment. Now, you probably know the long list of disorders for which CBT has been shown in randomized controlled trials to be effective. So I won't read through this entire list, but I will show you a research slide from this year, 2025, that looked at the major psychiatric disorders and found that CBT was more effective than the control conditions in these randomized controlled trials across all of these disorders. I don't know if you know of the many, many medical conditions for which CBT has been shown to be effective. This is just a very small list, but all kinds of pain, irritable bowel syndrome, colitis, fibromyalgia, insomnia, obesity, tinnitus, and so forth. You might know that CBT is used with children and adolescents and with adults and older adults. I also wanted to include the fact that we work with many individuals with trauma. At least in the United States, there are a number of therapists who think that CBT is not effective with trauma, and that is just not true. There have been many, many randomized controlled trials that show that it is. In the United States, at least, probably in Brazil too, we treat patients in individual therapy and group therapy and couples or family therapy. More and more in recent years, we have been using technology. There's internet-based therapy now, and certainly teletherapy as well. Now, CBT is being used in many different settings, in psychotherapy clinics, of course, in inpatient and outpatient medical settings, in schools, in residential placements, it's being used in community-based programs, in state hospital, and also in forensic settings, jails and prisons. You may not know, but there's some really fascinating research, randomized controlled trials that have looked at the effectiveness of CBT when it's delivered by non-professionals and has been found to be effective in all of these, but there are many more than these too. In Zimbabwe, the grandmothers in a community, the older respected women, are taught how to do some behavioral activation and problem solving. They sit on benches outside in the community instead of in offices. And they've been quite effective with people who would not seek counseling otherwise. The Manas program in India uses lay counselors, so not professionals, but people from the community who have been taught to deal with clients who are severely depressed, who have been in their primary care doctor's office. The Thinking Healthy program was developed by the World Health Organization, and that uses people who are already mothers to help new mothers who have become depressed using CBT interventions. In Indonesia, there are lay counselors who are using trauma-focused CBT with youth who have been experiencing trauma because of natural disasters and conflict. I recently went to a very interesting conference that had a number of programs from across the United States in large cities where they use community-based workers, people with lived experience, mostly people who had been previously in gangs, and they've been able to reduce gun violence in these communities through the CBT interventions in the READY program. So how was CBT developed? Well, it was really kind of an accident. When my father was doing his residency in neurology, there was a shortage of psychiatric residents. And so the director of the residency psychiatry program told all of the residents, including my father, that they all had to do 6-month rotation in psychiatry. Now, psychiatry at that point was dominated by the Boston Psychoanalytic Institute. My father was very unhappy about this requirement. He had been exposed to psychoanalytic psychotherapy when he was a medical student, and he really did not believe in it. It didn't make sense to him. He was very skeptical about psychoanalysis. But at some point, he decided that he should listen to his teachers, his professors, and his fellow residents and later fellow young psychiatrists, and he should give psychoanalysis a try. And he really became convinced that it was valid. And in fact, he underwent 2 analyses himself. But my father was always a scientist at heart. And when he became an assistant professor, he decided that he should do some research studies that he was convinced would validate the psychoanalytic concepts of depression. First, he studied the dreams of depressed patients and compared them with the dreams of a control group. What he found out was that the themes of the depressed patients did not reflect hostility turned toward the self, as should have been true if the psychoanalytic psychotherapy concepts were accurate. Instead, what he found was that their themes were very consistent with the themes of their thoughts and beliefs that they had when they were awake. In a second set of studies, he had depressed patients do a card sorting task and compared the results with a control group who did the same task. Well, the depressed individuals showed a greater shift in their mood, became more positive when they succeeded at the task, more so than the control group. And he concluded that it wasn't accurate that depressed individuals sought failure. They did not have a need to suffer. And he concluded that the unconscious motivational model was not correct. Then he began making clinical observations about automatic thoughts that his clients, his patients were having as he was still treating them in a psychoanalytic way, lying on a couch and doing free association. He observed with his own automatic thoughts and with the automatic thoughts of his patients that these automatic thoughts seemed to come before a shift in affect. And he began to develop the cognitive model. At this point, he asked the clients to sit up around a table with him, and he taught them how to systematically evaluate their automatic thoughts. What was the evidence that their thought was accurate? What was the evidence that maybe it wasn't? Was there an alternative explanation for what was going on? And so forth. And I think you'd be interested. You may never have looked at this 1963 paper, but it was called Thinking and Depression. And it was really a revolutionary paper that introduced both the cognitive model and cognitive therapy. Now, you might have heard of the randomized controlled trial that my father's major resident, uh, Rush, sorry, I'm blanking on his first name, John Rush, um, uh, and he and others published in 1977. They conducted one of the very first randomized controlled trials that compared cognitive therapy to imipramine, an older antidepressant. And it was the first psychotherapy treatment that did actually as well or actually a little bit better than pharmacology for people who were depressed. And it raised the standards of research in psychotherapy, and randomized controlled trials really became the gold standard. Not only was cognitive therapy more effective than psychopharmacology, but the patients who received cognitive therapy had half the relapse rate as people who took the medication alone. In his first real treatment book, Cognitive Therapy for Depression, that was in 1979, he introduced these new principles of treatment. Here were some of the very important things that he discussed. Treatment needs to be based on an individualized cognitive conceptualization. The therapeutic relationship is essential, and there are certain step-by-step procedures. Clients and therapists engage in collaborative empiricism, where they engage together in evaluating patients' thoughts, not challenging their thoughts, but evaluating their thoughts. He used a worksheet like the Daily Record of Dysfunctional Thoughts. He used a lot of imagery, not only to elicit automatic thoughts, but actually some patients' imagery are in the form of automatic thoughts. He did a lot of behavioral experiments with patients, and he also recommended Socratic questioning. He thought it was very important that patients and therapists together agree on the goals of treatment. And today we add to that, because of recovery-oriented cognitive therapy, an emphasis on values and aspirations. He recommended a certain structure to the sessions and said that action plans or the homework that clients did between sessions were essential. That's really how people got better. Now I'd like to talk a little bit about cognitive conceptualization. So we base the conceptualization both on the patient's strengths and on their problems. We begin the conceptualization at the very first appointment, which is a full biopsychosocial evaluation. We need to have a very accurate conceptualization in order to develop an effective treatment plan. And at the Beck Institute, we never use manuals because the treatment plans are so individualized. Although we don't use the manuals, we use the principles established by the randomized controlled trials as they're applicable to each client, depending on their diagnosis. Now, there's so many things we consider in making the conceptualization. The patient's age and gender, their symptoms, the reasons they're seeking treatment, their important cognitions, behaviors, and emotions, their sexual identity and orientation, their developmental level and stage of life. We take a complete history, including trauma and discrimination, and many, many other relevant factors. Now, we're never finished the conceptualization until the client terminates treatment because at every session, we get more data. And this helps us confirm our hypotheses or maybe modify them or maybe disconfirm them. We also make many conceptualizations throughout the session. So, patient, did I get this right? This was the situation. This is what you were thinking. And then this was your reaction. And of course, that's what we call the cognitive model. This is usually the oversimplified diagram that we show patients, although of course we understand that really automatic thoughts, emotions, and behaviors influence one another. I hope that you've seen this problem-based conceptualization diagram. You'll see at the bottom are 3 cognitive models, and you want to make sure that you pick 3 in which the meaning of the automatic thoughts differ from one another, if indeed the patient has different meanings of their thoughts. Those meanings are connected to the patient's core beliefs, their most basic beliefs about themselves, their worlds, and other people. And we understand why they develop those beliefs because of the meaning that they put to certain lifetime experiences. We also understand how it is that they developed certain coping strategies to get along in life. And the intermediate beliefs, the assumptions, help us understand why they use those coping strategies. If I use this coping strategy, then I'll be okay, at least for the moment. But if I don't, then maybe my core belief will come true. So that's the problem-based conceptualization diagram. In 2025, we now make a strength-based conceptualization diagram for each patient, and you'll see it has pretty much the same categories. Just want to talk about core beliefs for one moment. The reason that patients' core beliefs get so strong over the years is because of the way that they process information. They tend to focus very strongly on all of their experiences that seem to support the core belief. But something happens in a different way when they have experiences that contradict the core belief. In that case, the negative core belief, the positive data gets changed into a negative belief, or the positive data just seems to bounce off, just doesn't get integrated at all in the patient's mind. I'm going to quickly go through treatment essentials. I'm hoping that we'll have a couple minutes left for a question toward the very end. Okay, so we've already talked about the importance of a biopsychosocial diagnostic evaluation. We talked about the fact that the therapeutic relationship is very important, needs to be highly collaborative. We make sure and elicit feedback during sessions when we notice that patients are having a negative reaction. We ask them how they're feeling, what was just going through their mind. And when they are very upset with us, then we need to repair ruptures. And if I could leave you just with one important idea about the therapeutic relationship, whenever patients give you negative feedback, whether it's during the session or when you ask again at the end of the session, whenever they give you negative feedback, the most important thing for you to say is, it's good you told me that. Even if their feedback is incorrect, it's still important that they tell it to you so that you can fix the problem. We talked about the fact that the conceptualization needs to be ongoing and that we share our many conceptualizations with the client during the session and elicit feedback. We try to make treatment as short-term as possible. We tell patients at the first session, my goal is to teach you to be your own therapist. And that's why I won't only use techniques with you, but I'll teach you to use the techniques yourself. And by teaching patients to do the techniques of CBT and encouraging them to do them between sessions, we're able to make treatment a little shorter than otherwise it would be. Now, while the sessions are very structured, they really sound like they're a conversation. Both the therapist and the client are quite active, and at the beginning of the session anyway, the beginning of treatment, we really emphasize current problems and the goals that patients have. I mentioned before, we do not challenge patients' cognitions. Rather, we evaluate them with the patient. There's a very strong emphasis on behavioral activation. We tell patients that it's not enough just to come to treatment for once a week. They need to learn things in every session that they're going to practice at home. And that the way that people get better is by making small changes in their thinking and their behavior every day. And we've mentioned the real strong emphasis we put on relapse prevention. I'd like to tell you very quickly about some additional principles of recovery-oriented cognitive therapy. Recovery is when people are living the life that they want to be living. A life that's in alignment with their values and their aspirations. And the goal is less to decrease their negative emotions and negative cognitions, although, of course, that's important. But it's even more important to strengthen their sense of connection, their sense of hope and purpose and empowerment, their sense of safety and well-being, competence and control. Now, my father and Paul Grant, who's the director of recovery-oriented programs at the Beck Institute, developed this recovery-oriented cognitive therapy for individuals diagnosed with serious mental health conditions, such as schizophrenia and bipolar disorder. But we have really now applied it to the outpatients whom we see who have just more acute disorders like depression, anxiety, eating disorders, substance abuse, and so forth. I mentioned these first two elements already. Let me mention number 4. We put a greater focus on eliciting goals for the session and goals for the coming week that the patient has, rather than eliciting the problems they've had in the past week. I mentioned again a greater focus on identifying values and aspirations and linking them to the goals for the session and also to the action plan to motivate clients to do the hard work. We have a greater focus on reviewing their positive experiences and drawing adaptive conclusions then about themselves, other people, and the future. And a greater focus on building their resilience, noting their signs of adaptive coping, their competence, and control. Now, I really think it takes a lifetime to learn CBT. I always tell people I'm a much better therapist than I was 5 years ago. In fact, about every 5 years, I find that I've made a leap in my effectiveness as a CBT therapist. Certainly in the last year, it's been due to learning so much more about recovery-oriented cognitive therapy. But here's what new research has shown us in the past few years, and I think will continue to help us become better therapists. One is we're going to learn how to personalize treatment much more based on a patient's neurobiomarkers. We're going to learn much more about how to adapt CBT so it's culturally appropriate for each individual patient. We're going to continue to identify what are some of the underlying psychological processes that are transdiagnostic that lead to the mechanisms of change. And we're going to continue to use recovery-oriented principles to improve our outcomes. I don't know if you've already, some of you I'm sure have been experimenting with some of the new technologies to improve treatment. I have been very much impressed by some of the apps and the AI programs that people with mild difficulties, I would say probably mild to moderate disorders, can really get effective treatment through therabots. But I do have to warn you that the therabots are not programmed well enough to pick up when people are homicidal and suicidal. And there have been at least 3 deaths already, I think probably more at this point, of individuals who have used therabots. And the therabots initially, when they have expressed suicidal ideation, the therabots have encouraged them to call suicide hotlines or to see a therapist or to tell other people. But when at least these 3 individuals persisted, the AI programs actually encouraged them in their suicidality. So I feel so very mixed about artificial intelligence. I think it has the capability of helping people with mild to moderate problems throughout the world, people who could never get access to a mental health professional. On the other hand, I think it's still too early to disseminate these tools too widely until there are many more safeguards in place. I think what we will also see is an improvement in CBT by integrating other modalities like transmagnetic stimulation, psychedelic drugs, drugs like cycloserine, and mindfulness. And I think we're going to see many more programs like the 5 that I mentioned before, in which we can train non-professionals to use CBT interventions. Okay, now, I hope that I've motivated you and that you want to take some more steps on your own journey to becoming an excellent CBT therapist. So here are a number of ways that you can do that. First of all, ArtMed, the publishing company, the education company, I should say, has published many CBT books. Maybe some of you have seen Cognitive Behavior Therapy, Basics and Beyond. And I published it in English in the year 2021. It is the 3rd edition. If you've seen either the 1st edition or the 2nd edition, you won't see any mention of a recovery orientation. You won't see anything about aspirations and values and drawing conclusions about positive experiences. You will only find them in the latest version, the 3rd version of the Basics and Beyond book. Now, the next book is Recovery-Oriented Cognitive Therapy for Serious Mental Health Conditions by my dad, Paul Grant, and colleagues. And I think it's a very interesting book, even if you do not treat and never intend to treat individuals with schizophrenia or bipolar disorder. I think you'll learn quite a lot about a recovery orientation that you can apply to the patients that you see. And before I forget, I just wanted to mention again that I will be coming to Sao Paulo on November 13th for an ArtMed conference on CBT, and I hope to see some of you there. Meanwhile, we have already recorded 3 courses in Portuguese, one on CBT for personality disorders, one on anxiety, and one on depression. And I have either conducted all of these courses or I've written them, and I've certainly appeared in all of them as well, although I'm not necessarily the major teacher for all of them. And we have 2 more courses that are coming up. The Basics of CBT, which starts on September 24th, and a really important course, CBT in Practice, which starts in October. And you can either join these courses live or they will be recorded so that you'll be able to take them whenever you want. The CBT in Practice course is very important because it teaches you how to use the CTRSR, the Cognitive Therapy Rating Scale Revised, that we developed at the Beck Institute. And it goes through each item, each 11 of items in this scale, and teaches you exactly what you need to do for each of the items to be able to show that you are a competent CBT therapist. I hope that you will go to beckinstitute.org. There is some way that you can translate the website into Portuguese, and I meant to find out how to do that before tonight, but I forgot. So I'm sorry. Maybe we'll send out an email that would tell you how to do that. I hope that you'll look at it. You'll see so many free resources. You'll see resources for COVID-19. You'll see all kinds of free worksheets. You can read blogs and articles that my dad and I and our faculty have written. You can watch some free webinars and video clips, and you can sign up for our Beck Institute newsletter. I hope you will sign up for it. It comes out once a month, and we talk about some of the cutting-edge advancements in CBT. We hope that you will also check our website to find out all about our workshops and our webinars, almost all of which are virtual. We have supervision and consultation programs, and you can become certified by the Beck Institute. We have our social channels that I hope that you will go in and comment on. And again, I mentioned this at the beginning of the talk. You can email us and then get a list of all of our free resources. So I hope that I have taught you a little bit tonight, some things that maybe you'll be able to use tomorrow. And I hope I've motivated you to continue your journey to become an excellent CBT therapist.